It's important to realize that the BEAR, it's not new, it's just different. And it's a different thought philosophy that we have. And it's something to keep in mind that this has been investigated for over 20 years. And we've gone through sort of an iteration of research when it comes to ACLs, where we tried to repair them initially, and then we went to reconstructing them and replacing them. And now we're back to, can we restore them with the BEAR implant? And restoring is the key word there, because we're preserving what's left and putting it back to where it belongs, much like everything else in the body that we treat, like rotator cuffs and MCL injuries. One of the things to consider when you're looking at the BEAR is, how does it work? Well, to do that, we have to understand exactly what the BEAR implant is. And it's a decellularized bovine collagen implant that's able to hold and protect blood in the area of healing where the ACL will reform up against the femoral wall or the tibial plateau. And it blocks out the synovial fluid that we know can slow down the healing process and prevent the clot formation from occurring. It's highly porous, and we know that it resorbs over the course of about 8 weeks, and the procedure can be pretty straightforward once the steps are learned. One of the things to think about, as I mentioned earlier, is the MCL, the rotator cuff, all these different pieces of tissue inside the body can heal. And the way they heal is by scarring and by clot formation. These are extra-articular structures that we're talking about primarily, whereas the ACL is more of an intra-articular structure. And we know that the synovial fluid that builds up around the ACL, particularly after a rupture, when the negative enzymes are released inside the joint, can prevent that scaffold and that clot from forming, basically breaking down the ability of the body to heal the ACL up to the femoral wall or the tibial plateau. The BEAR helps to prevent that. So through clinical research and through clinical studies, we've been able to examine the outcomes of the BEAR. And when we talk about something being new or novel, it's important to realize the BEAR, as I mentioned, has been around for 20 plus years. And there's plenty of research and data that's out there, including level 1 studies, which is different for most of the novel things that we do in orthopedics. Thinking about some of the most key research that we found from the BEAR, we can go ahead and look at things like IKDC scores, re-tear rates, and functional outcomes. So in the BEAR 2 pivotal clinical trial, they assessed IKDC as well as AP laxity at 2 years. And what they found was, in a side-to-side comparison between the BEAR and ACL reconstruction using hamstring tissue, they found that the KT1000 scores were essentially equivocal. And they also found that IKDC scores were actually higher in the BEAR group than the reconstruction group. It stands to reason, without robbing the hamstrings for the reconstruction, the hamstring strength in the BEAR group was also much higher than in the ACL reconstruction group. Looking at the sagittal plane and looking at the ACL in the contralateral knee versus a BEAR restored ACL, you can see that the angle and sort of the kinematics that are maintained in that sagittal plane are really important, and they're the same. So when you think about how good we are with what we do now with our reconstructions, whether it's outside in drilling or anterior medial drilling, we're still never able to recreate that normal angle of the ACL as much as we really think. By being able to restore the ACL to where it belongs, we're able to preserve that function. And in my mind, I think that helps minimize the risk of arthritis by creating and restoring the kinematics that we were born with. And again, as I mentioned, we know the BEAR goes away by 8 weeks, so that ACL tissue is there, attaching the femur to the tibia and allowing some of those proprioceptive fibers to be in contact earlier on, minimizing the risk of micromotion.